Welcome back to your favorite science podcast. Today, we are talking everything sexual health. By the end of 2025, Kenya recorded an alarming increase in new HIV infections. Recent research also showed an increase in STIs among teenagers, with young women being twice as likely to be infected. We'll unpack the complex reasons why women are at a higher risk, discuss the urgent research for new prevention tools beyond condoms, and demystify life saving interventions like the HPV vaccine. We'll also tackle one of the biggest barriers to progress: the silence around sexual education. Our guest is the Senior Principal Clinical Research Scientist at the Kenya Medical Research Institute, KEMRI, in Nairobi, Kenya, and a leading global health researcher. She is none other than Professor Elizabeth Bukusi, who I'm very excited to have here with us in studio, and is a research professor working within the fields of obstetrics, the word I can never seem to say, obstetrics, gynecology, and global health. Thank you, Prof. Her work focuses on sexually transmitted infections, reproductive health, and also HIV prevention, care, and treatment. She led a landmark study on the use of pre-exposure prophylaxis, also commonly known as PrEP, in Kenya, and has been on the front lines of other research into prevention of STI transmission and also the HPV vaccine. Outside the lab, she is equally remarkable: a Sunday school teacher, a record-setting mountaineer, and a weightlifter who inspired hundreds online by competing at the young age of 58. Professor Bukusi, karibu sana to the podcast.
Thank you very much.
Before we go into the science, the deep science, let's start with the inspiring balance you have in your life. You went viral a few years ago for weightlifting, and before that, you climbed Mount Kenya. Are you still actively lifting, and are there any new physical goals on your horizon? I dare say Kilimanjaro.
Well, Kilimanjaro can't be a target because I've already done Kilimanjaro. So
know.
let's talk about something else. Maybe the target for me would be to go back up Mount Kenya and get to the highest peak that is called Batian. I have attempted it once. That was almost 25 years ago. I didn't make it to Batian, but I made it to Nelian, the second highest peak. But the weather was so bad that we had to turn back. Very difficult decision, but you need to stay alive in order to be able to climb a mountain again. So there are always new opportunities for setting new targets and new opportunities for growth. Am I still lifting? Yes, I am. Not necessarily heavy, not necessarily going into competitions, but I won't rule it out that I could go back into competition again. But things like exercise are things that you just need to do it because it's a way of life. You need to keep your body active and moving. That's the way to stay healthy.
And, you said you've been 25 years ago was your first attempt for Mount Kenya. In fact, it's interesting because many of our listeners at the moment are between the ages of 25 all the way to 45. So even some of them, you might have been in the delivery room when they were being born. So let's go back to your medical attachment as a young woman professional coming up, going back to your medical attachment in Western Kenya. Are there specific experiences or moments during that time that pointed you toward a career in gynecology and research?
Yes, they are. If you had asked me as a medical student, what did I want to do? I would have told you a pediatrician. I loved working with children. And I thought that's what I was going to do with myself, work with children. But when I did my internship at Kenyatta, I found it very hard to work with children. Children are lovely and they're very genuine, but the challenge was when they were very unwell or when I lost a child, I was completely devastated. I struggled emotionally to let them go, and I struggled to not to be too connected to them. So I realized that for me, pediatrics was going to take a toll on me. It was going to be very difficult for me to function in that space. In the pediatric cancer ward at Kenyatta, when I worked there, I would even volunteer to do extra calls because some of my colleagues weren't very good at getting the veins, the intravenous injections we needed to give them. And I would feel bad when children were pricked over and over again. So there was one particular young doctor, and some of these things are just a question of skill. You're very good at one thing. He was a good doctor, but he just struggled. So when he was on call, I would volunteer to go and work for him so that he would not be pricking the children 5 times before he eventually got the veins. But then when I went to work as a medical officer on the border of Kenya and Uganda, and if you remember, because Uganda is landlocked, a lot of things that go into Uganda would go through truck routes. That was when HIV was really raging in the country. And one of the things that was promoting transmission of HIV was long-distance truck drivers. Remember, these are people who would be away from their families for a long period of time. They not only drove into Uganda, they drove all the way into DRC, so long periods. So what happens with such men? Of course, there are many sex workers along the route. And so part of their entertainment when they're, off work would be liaisons with the sex workers. So this was literally what we'd call the death route, because there was a lot of transmission happening along the highways from Mombasa all the way to either Busia or to the other border towns, and then into Uganda and going on into DRC. So when I worked at the border town, we saw so many sexually transmitted infections. And that was one of the things that started making me think about what else could I do? I also saw very many women who came in with complications of pregnancy. And every time we lost a mother, I realized how devastated a family would be, especially a young family. A woman would come in labor and would come in having tried some herbal concoctions to try and make the labor go faster. She'd end up with a ruptured uterus. If we didn't have enough blood, she would pass away, leaving behind young children, families that were really devastated. And just the plight of women and their health is what made me start thinking about obstetrics and gynecology. But it is also what made me start thinking about HIV. Busia is a malaria town. And so young children would be coming in with severe malaria, so anemic they were gasping for breath. Of course, who do you ask to donate blood? The parent. The assumption always is that the parent must share a blood group with one of their children.
Right.
Now, a story for another day is, of course, sometimes those blood groups didn't match up, and the question would be, whose child was this? But, that's a different story.
Yeah.
But in those days, we didn't have rapid tests. We asked people to donate blood, and then we went and tested the blood for HIV and other transmitted pathogens. And in the 2 years that I worked there, from discarding 1 unit of blood out of every 10, we're discarding 5 or 6, meaning there was so much HIV. And that is what sort of pricked my attention and made me realize we needed to do something. The first person diagnosed with HIV in this country was diagnosed when I was a fourth-year medical student. And somehow at the back of my mind, I realized HIV was going to change the trajectory of my life as a medical doctor. But I also didn't want to have fear be what drove me. Because in those days, there was so much fear about HIV. If somebody died, we wrapped them up in big black plastic cloths and big black plastic papers. Just the same thing we're seeing with the contagion fear during COVID.
Yeah.
That you wrap them up because you don't want them to infect anybody. And then you want to take them and then put them away from everybody else. And as medical students, we would go into the ward to do a round, and the consultants would stand outside the door. They would send us medical students to go in and see and then, come and talk to them, and they'd tell you what to do. It's like people have this fear of contagion. Yeah, it might catch someone, let it catch someone else, not me.
Yeah.
But I was determined that would not be what would be my story about dealing with something like HIV. So yes, my early years made me think I needed to do something for women, but I also needed to do something about sexually transmitted infections and HIV. That's what made me go back to study obstetrics and gynecology, but that's what also pushed me into the research world.
So what a beautiful story and background, about your transition and your career trajectory to working now with HIV. But, there've been such significant gains in the last couple of years that I'm wondering what is happening in terms of even when you think about the SDGs and maternal deaths, and women and women's health, young girls. There's been a lot of concern about the rise of new HIV infections, certainly in Nairobi County, and the spread of STIs. Young girls and women are twice as likely to get infections. Why are they at higher risk?
There are a number of different reasons. Let's start with the biological ones. Young women are at risk because biologically their systems are not as mature when they're aged between 16 to maybe 18, 19.
Yeah.
They're still developing their protective mechanisms because they're natural protective mechanisms in the body that help stop the possibility of getting HIV. We talk about a production of something that we call lactic acid.
Okay.
And the acidity within the vagina then makes it less likely that someone would end up getting infected. But there are many practices that people do, and unfortunately, often they're passed on from one generation to another. Douching,
Yeah.
washing on the inside, and then using different kinds of creams,
Soaps.
emollients, soaps. I've even
Lads.
heard of people talking about using Coca-Cola,
Oh my God.
So there are all these things, and unfortunately, these things destroy the natural bacteria that are there that are protective, therefore making it much more likely that someone would end up being infected. Apart from the fact that when they're young and the lining of that particular area is much more prone, then that makes them more likely. When you think about the biology of it as well, remember that the way the female vagina is, it's a receptacle. So it retains fluids.
Yeah.
So just the retention over a period of time. Therefore, if you think about it, just the penis doesn't retain unless one is not circumcised. And that's why people have been talking about voluntary medical circumcision, because then the ejaculate and the secretions are not held under the prepuce,
Yeah.
which would then increase the risk of transmission of sexually transmitted infections, including HIV. But the female vagina is a receptacle. And so retaining those fluids there for longer just means one is much more at risk. Not to mention that there's the whole of the lining of the inside of the uterus, so many opportunities for where infection could happen.
Yeah.
But apart from the biology as well, remember that the sexual act in and of itself, it's never quiet, and it's actually the process in and of itself. There are microabrasions that happen just because of the activities.
Yes.
And as a result, of course, again, women are much more at risk. But apart from the biological mechanisms, there are the social determinants. Unfortunately, we still live in a world where we are predominantly male-centered in terms of power, in terms of money, in terms of decision-making. So many women are not empowered enough to be able to make choices or decisions about when they start having sex, who they have sex with, and whether they can protect themselves.
Right.
Many cannot negotiate for safe sexual practices, like even use of condoms, whether it's male or female. Many young women are put at risk because they're having sex with older men who are likely to have acquired infections. So they're not having sex necessarily with the age cohort who are less likely to be infected. It's older people who are likely to have acquired infection over a period of time. In addition to that, there's the question of the power dynamics. Why do young women get into sexual activity? A lot of it is socio-economic circumstances. We tell stories are told about chips funga.
Yeah.
Just to get a meal.
For non-Kenyan listeners, chips
Yes.
funga.
It's talking about getting chips or French fries.
Yeah.
For a sexual act.
Yes.
Young women will have sex to get money to buy pads because we don't make basic necessities like sanitary pads affordable and available for young women.
Right.
It's the same reason many young women miss school. Who wants to walk to school and have the potential of soiling yourself?
Yeah.
Or being stigmatized for a process that is natural, that is normal, that is what contributes to the fact that we as human beings can stay alive because of procreation. If we stop procreating, we will be extinct.
In days.
But those natural processes are not taken care of. Because unfortunately, power speaks, and the power speaks in places where things that don't matter to people in power stop mattering to others. And so women's health issues are rarely prioritized from that point of view. So these are the things that put young women at risk and therefore put them at risk for getting sexually transmitted infections. In fact, there is data that shows that for many young women, up to 3/4, the first sexual act is not one which they have willingly consented to. It's coerced or it's actually an abusive relationship.
And I'm sure, what is the onset of sexual activity for young people in Kenya?
We think it's between 15 to 16 for young women and between 17 to 18 for boys.
And the chances are this is not, as you've said, in their age groups.
Not in their age
with
groups.
The older.
With older, and for young women in specific, it's likely to be coerced or an abusive relationship, not consensual. And many young women don't know that if I say no, someone should respect my no.
Yeah.
Because unfortunately, the interpretation is if I say no, it's a maybe if you persuade me, or maybe if you push me hard enough.
And your point about the fact that it's a social economic that contributes to it. It's our paternalistic society. The power dynamics being one of the things, because the discussion is usually that, oh, this child or that girl is promiscuous, or they know too much about sex, which is actually contradictory to what we see even when we talk about sexual education, which we'll come back to. But I want to talk very quickly about a study that you involved in 2023. The one on the use of a certain drug to prevent contraction of STIs. However, that study in itself, called doxypep, did not go really as planned. So I
No, it
want to
didn't.
hear a little bit
It
about
didn't. It
why.
didn't.
And then why is it so urgent that we find ways of preventing the contraction of STIs, especially for women and especially for young adolescent girls?
Okay, let's start with the doxypep.
Yeah.
So we talk about PrEP, pre-exposure prophylaxis, and we talk about PEP, post-exposure prophylaxis. Now we talk about those both for HIV and sexually transmitted infections. So what we'll be doing in doxypep, we know that sometimes, because women cannot negotiate, and young women, safe sexual behavior, the question is, if you do end up with a sexual exposure that could put you at risk, can we give you a pill to take after the event?
Yeah.
And then that's what stops you from getting the sexually transmitted infection. That's the PEP, post-exposure prophylaxis. Doxycycline is a well-known, well-tolerated, well-utilized licensed drug. And our attempt was to show if the young women take the doxypep after they've had an encounter which they think, whoops, that could have been risky and I didn't use condoms, could we then protect them from getting sexually transmitted infections? Unfortunately, the reason it didn't work was because the women weren't taking it. They reported that they were taking it. They came back to clinic faithfully. And these were young women who were at high risk because they were taking pre-exposure prophylaxis for HIV.
Yeah.
In other words, they were already aware that they were at risk enough that they were willing to take PrEP,
PrEP.
pre-exposure prophylaxis.
Yeah.
So those are the ones who were now giving an additional support for PEP, post-exposure prophylaxis, to see whether we would stop sexually transmitted infections among them, because we had already picked up the fact that young women on PrEP, HIV PrEP, had high rates of chlamydia, high rates of gonorrhea.
Yeah.
But they were not taking the PrEP. Why weren't they taking it?
Yeah.
The study actually started during the time of COVID. Economics were crazy at that point in time. People were struggling. People weren't going to work. Many of these people were in casual jobs and so on. And so because they were struggling probably, and it was hard for them to even have meals, that's probably one of the reasons they didn't take it, because it does cause discomfort if you don't take it with food. We were actually providing them with a little bit of support to try and make sure they could take the medication. But when we tested hair samples, because we can actually test hair samples for drug levels, we realized the drug levels were very low.
Yeah.
From the numbers who say they took it, less than a third were actually taking the medication as required. So it's not that it doesn't work. Medication may work, but if it's not taken, it can't work. It's the same thing we say with pre-exposure prophylaxis.
Yeah.
It works if it is taken. If you don't take it, it doesn't work.
Oh.
So that was the reason. And why is it so important that we should do this? Particularly for young women and for women in general, sexually transmitted infections do not always show up with symptoms. What do I mean by symptoms? For men, if a man has a discharge that's causing pain or an ulcer that they can see, that will make them go to a health facility.
Yeah.
For a woman, they may have an ulcer that they can't see. The female organs don't make it easy for you to see,
Right.
number one. For two, the women will not have a discharge in the same way as the men are. They don't get the same kind of purulent discharge, and they don't have the same type of pain that the men will get. The men will get severe pain on passing urine.
Yeah.
That's enough to send a man
to the hospital. Yeah.
And then many of them, because it's what we call asymptomatic, there are no symptoms showing, they don't have anything that makes them feel discomfort, they stay without getting treatment. But the sequelae or the consequences are very severe. This is what leads to things like infertility. Or if someone does get pregnant, can lead to infections that lead to early delivery, premature deliveries, and can lead to complications of childbirth. So the sequelae for women way downstream are very high when sexually transmitted infections are not treated on time. And often they're not treated on time because they're not picked up. And men will get infections, may pass it on to their partner, but will not tell their partner. And so the partner stays with the infection, smoldering, causing them discomfort for a long period of time before they realize it. And one of the most severe consequences are what we call pelvic inflammatory disease, pain, continuous discomfort, and difficult to treat. And there are women, you'll find older women who have had low abdominal pain for years on end.
Yeah.
And the challenge is sometimes people can't differentiate. They think, well, women are bound to have pains in the lower abdomen. It's just part and parcel of who we are. It's life. It's not life. Someone shouldn't be having discomfort and pain. It's not a way of life.
Of course, it's not. And I want to emphasize that 1 in 10 adolescents is infected with chlamydia, gonorrhea. Majority of adolescents who tested positive, like Professor Bukusi has said, showed no symptoms at all, with adolescent girls twice as likely to be infected as boys. Prof, let me change gears a little bit. Still in the realm of STIs and HPV and HIV, let's touch on the human papillomavirus. What is it? And also, please talk to us about the vaccine for which you were part of a pivotal study on this HPV that resulted in the development of the vaccine. And just, talk to us about who should get it, when should they get it, and its importance, really.
Okay, that's a mouthful of questions.
I know, sorry.
So the human papillomavirus, it's one of the most, we say it's ubiquitous. It's a very, very common virus. There are specific strains of that virus that we are concerned about that are more likely to cause cancer. Now, they cause cancer of the cervix. They actually also cause cancer of the penis. And interestingly enough, in fact, last week I was talking to one of the urologists in Kisumu, and he was telling me he's seeing so many cases of penile cancer that he's actually concerned about it. He was saying he wants to champion that young men need to get HPV vaccines, which is a different story. But why are we concerned about it? We are concerned about it because cervical cancer is preventable. It is preventable. It is also treatable. In other words, cervical cancer is a cancer we can completely eliminate from the face of the earth. If we can vaccinate enough young women, and we're targeting young women in specific because of the high rates of cervical cancer, but in countries where they have more resources, they're targeting both the young men and the young women. Who should get it? Young women. We really should target before they start sexual activity. So somewhere between 9 to 14 is ideal to make sure that they get the vaccine, and then that prevents them from being able to pick up the viruses. Now, people pick up those viruses, and then our bodies are able to get rid of them most of the time. But when they persist and our bodies, for some reason, are not able to destroy and completely get rid of the virus, that's when they're likely to develop into cervical cancer many years down the line. The challenge, however, is that it's very hard for most parents to think about their lovely 9, 10, 11-year-old as a person who will potentially have sex at some point in time and who needs to be protected. But that's what we do with vaccines all the time. You give your child a vaccine because you're protecting them from infections that they could potentially pick up much later. So in the ideal world, we want to give them between 9 to 13 or 14. People who have not had sex.
And is it just a one shot?
Now, that's the study that we were doing. The vaccines had been developed, but initially the goal was 3.
Okay.
And the challenge is most countries could not afford to actually make that coverage of 3. In fact, in Kenya, people made a lot of efforts to get the vaccine out, but we're hitting a coverage of perhaps between 50 to 60 for the first dose, let alone the second and the third, which would even be less. And then we didn't have the resources. So the study we did was to be able to show, if we just give 1 dose, does that give us sufficient coverage to actually protect these young women from being able to develop the potential for cancer later on? Do they have enough what we call antibodies? Are they developing the muscle, as we would want to call it, that helps protect them from the virus? And we're able to show 1 dose works. And now, literally, WHO has made the recommendation, and countries are turning to one dose only.
Oh, wow.
So now the goal is, can we get them in? If we don't get them in, we can do a catch-up. In other words, we can still catch them somewhere between 16 to 24. Those who are HPV negative, we can still give them the dose and it will protect them. If we can mop up and allow the young women to get the vaccine, we would say let the young men also get it, because then it means they are not also going to pick it and pass it back on. We could protect a whole generation from ever having challenges with cervical cancer or penile cancer in the future.
Wow, I have so many questions. Let's go back to you were about to say about coverage, 50 to, you're saying 50 to 60%?
That's what we were trying to hit, between 40 to 60, but
Yeah.
only for the first vaccine, not even the second. And even then, there's attrition.
Yeah,
Because just because someone got the one vaccine doesn't mean they will come back for the second.
right.
So the goal was, can we try and just give the one and then raise our coverage? If we can get our coverage to over 80%, we will have done very well.
Yeah, I mean, even you were talking about the fact that a country, a nation, regions can get rid of cervical cancer, and it sounds like the vaccine is a good
Does work.
direction
New
to
Zealand
go.
and Australia have been able to do an amazing
I
job.
was about to ask you about the
Yes,
Australian
they
study
have been able to do an
recently.
amazing job, and they are literally eliminating.
I mean, that's amazing. And so the shot, you said there were three. The first one, how much does it cost? And then when do you
The
supposed
government
to
has been
get the
making it
second one?
available free, even within private
Oh,
facilities. And
wow.
the private facilities will only charge you for the use of the injection or their swabs or their personnel time, but not for the vaccine itself. But this was under Gavi. But
Yeah.
of course, the challenge is now that with the Americans pulling out, there are going to be challenges with making vaccines available. But Gavi has also had a very good model where they provide you with support, but they help the government work towards being eventually able to support its own immunization programs as they transition you over a period of time. So the vaccines have been available. The
Yeah.
question is just convincing parents to take their children. And then even through the school programs that are trying to provide it, because we do need parental consent in order for the young person to be able to get the
Yeah.
vaccine.
And I mean, it sounds like we need a lot of also sexual education, science communication to be able to make people understand what we're trying to do. I mean, I'm not sure if the message has been passed hard enough about cervical cancer being one of the top 10, if not the number one killer for women,
It is definitely one of the higher ones there. Between cervical cancer and breast
and
cancer,
breast cancer. Yeah.
yeah, they are the highest. The challenge is that with cervical cancer as well, by the time many women present, it's so late. And then it becomes this stigmatizing illness because by that time they have huge ulcers, which are infected. It's terrible. They honestly suffer excruciating pain and die very needless, painful, stigmatized, isolated deaths because the wounds are smelly. Nobody wants to be near them. They're kept far away. And by that time, there's very little that medical help can do to be able to reverse it when it comes in stage 3 or 4. But it's entirely preventable.
Yeah.
And the challenge comes back to what you were saying earlier about the concern around sexual education and the fear that people think that when you talk to children about sex, you're encouraging them to have sex. But I think very many studies world over have shown that when parents take an active interest in not only talking to but educating their children about sexual matters, but also instilling in them the values that they hold and believe, those children are much more likely to make appropriate decisions about their own sexuality when and if to actually start having sex and with whom.
Yeah.
But when that education doesn't happen, really, very important issues, we are leaving our children to make decisions in the dark because they have no information. They will use whatever information their peers may be passing around, which could be myths, which could be misconceptions, but that's the best that they will have. So any parent who's not providing that information for their young children, for their young teenagers, and for their young adults, and not having those conversations with them, it becomes a challenge.
Yeah. You've really entered into the next question, which was on sexual education. And when you're not at work at KEMRI, you are a Sunday school teacher working very closely with teenagers. The ones that we're now talking are the target group for sexual education and also for the vaccine. As a researcher, a grandparent, and a person of faith, what advice do you have for parents and religious leaders who are hesitant to have these vital, uncomfortable conversations, if I can call them uncomfortable? What guidance would you really give?
I would say, first of all, acknowledge that it is uncomfortable.
Yeah.
It's difficult for most people. For those of us who are gynecologists and working in this field, it's our bread and butter, so it's easy for us and for those words to roll off our tongues. But for the majority of people, it is hard. But when you acknowledge that it is hard, that's where you want to start the conversation. Because parenting isn't about doing easy things. Parenting is about doing the difficult things. You don't wake up and just sort of say, whichever school, I'm going to toss a coin in the air, and wherever it lands, that's the school my child is going to go to.
Yeah.
You do due diligence. You look at what can you afford. What's the best education you can give your child with whatever means you have. It's the same way when it comes to issues of sexuality. What's the best that you can do for your child? And the best is for you to be able to give them sound information beyond facts. You want to be able to pass on your values. What are your personal values? Sex is this thing that everybody does, but nobody wants to talk about. You know, most of us, I don't know if any of you here are a result of IVF, but the majority of us, it's because somebody had sex.
Right.
That's how we came into being.
Yeah.
So we need to demystify it and stop treating it like it's something dirty and to be put under the table. Sex is a beautiful gift. It is something that is worthwhile. The question is when and with whom and how. That's what we need to talk about, so that they have a clear understanding. Your bodies are a gift. It is something beautiful, but you do need to make your choices about how you take care of that body, how you treat it, and what you do with your body. And the issues of sex then fall into that sex is a gift. When you have sex, whom you have sex with, why you have sex with that person, and that sex should be safe
Yeah.
and appropriate and legal. Because remember, actually, under the age of 18, as per the law, you really shouldn't be.
Yeah.
Because there is it's a responsibility. It comes with responsibilities because of the connotation that it does. It is the opportunity for also reproduction, which has a big responsibility to it. You know, once you've had a child, that child is yours for life until either you're not there or they're not there. That's a huge responsibility for a whole nother being and a whole nother life. So when you're 13 and you really aren't ready, that's not the time to be risking opportunities that could change the whole trajectory of your life.
Yeah.
So it's an important thing that parents need to be able to take on. And even if it's not an easy topic, there are many opportunities where you can get trained and can start to develop the skills that will help you be able to talk not just about the facts, but also about values. And that values is very important. Schools will tell your children about the facts of biology. That doesn't give them the life skills automatically to make appropriate choices and appropriate decisions.
Yeah. No, I really love that. And you use the word ready, and sometimes people think it's ready mentally and emotionally, but people forget the biological, body of a young child. Sometimes it's not even ready to be able to conceive and hold a child. You're still a child yourself. So your system needs to grow and mature and also not expose you to also infections that you have talked about. So when we talk about people who are over the age of 24, maybe people who've not received the HPV vaccine, is there still hope? Can they still get the vaccine? And what does that look like?
I think it would be, I would advise them, first of all, to get tested. We have very many available tests for HPV and to be able to
Is it the
confirm.
pap smear?
No, not the pap smear is different. The pap smear is about looking at cells to determine whether there are any changes that potentially would raise concerns for us to show whether there's an infection or whether there's any early cancer detection. That's the HPV.
Okay.
But now we do HPV testing. We just test for the virus itself. We know that it's the virus and persistence of the virus that actually leads to the changes that cause cancer.
Okay.
So if someone is over 24 and they should get tested, if they don't have and they're not infected, yes, they can get the vaccine.
Yeah.
But they would probably have to pay for it. The government isn't going to pay for you at that point in time. You have to pay for your testing and you have to pay
How
for
much
your
does it
vaccine.
cost?
It depends on where you're getting it.
Okay.
So yeah.
Range?
It's hard to give a ballpark figure because people, and right now there's a lot of changes with the import taxes. So costs could be,
They vary.
yeah, they could really, really
Fair
vary. So depends on your provider. So I don't want to give a cost and then be told, this is what you said
This
it
is what you
costs,
said.
and
I
it
know, I
doesn't
know,
cost.
I know.
So it's really, really variable. So I would say get tested, and if someone wants to get the vaccine, then you would be able to get the vaccine. So it's not all over for you, so to speak.
Yeah.
But the important thing as well for those who are over 24, especially if you are sexually active, get your testing regularly in terms of whether we don't say now just go and get a pap smear. We just get an HPV test. That will tell you whether you need to be concerned or not.
Okay.
Yes.
Okay. Professor Bukusi, we've come to the end of the recording for this podcast. Your call to action and your final words.
My final words would be to say that sexuality is something that is important. It's important to all of us because it is part of what makes us who we are as human beings. But I'd like to tell you, as a final call, we have a very exciting opportunity to build capacity for people on the continent of Africa to be able to address these same issues of concern, including sexually transmitted infections. At KEMRI, we have a fellowship that we're calling the LAIR-WH, the Leadership for Innovation and Excellence in Accelerating Research on Women's Health. We're hoping to be able to train fellows to address concerns about women's health on this continent, including sexually transmitted infections and other things that cause challenges for women, heavy menstrual bleeding, and all kinds of things. So it's an opportunity to address the health of women in this continent by researchers who are from this continent. It's one of the things that I hope will be able to turn the tide for women on this continent and be able to change the story about women's health. For anybody who's watching and is not necessarily a researcher, my call to action would be each one of us has a responsibility because you only have your life once, and your health is actually your best investment. So making sure you're taking good care of yourself, whether it's making appropriate choices, whether it's getting a vaccine, whether it's encouraging somebody else who matters to you, because your emotional health may be very vested in that person, to make sure that they get the appropriate care that they need, would be very keen. We only live once. So it's our responsibility to live in the best way that we can while we're here.
Professor Elizabeth Bukusi, thank you so much for those wise words. Yes, your health is your best investment, not your parents, not your spouse, not your children. It is your best health investment. Thank you so much for joining us, Professor Bukusi, and thank you to our listeners for sticking with us. Keep the conversation going on all our social media channels, CTD Pod Africa. Find us on YouTube, Instagram, LinkedIn, and also TikTok. This episode is brought to you by Silink Global and is recorded here at iHub Nairobi. Remember to always stay bold, stay curious, and keep asking the question why. Thank you.